Thank you very much, Rhonda. Let me just assure you that the fact that the media is not here in person is not because there is no media. In fact, there has been media coverage since yesterday evening. Canadian press picked it up. It has been on CBC, CTV, various radios, television, and also even it has reached Manitoba and Saskatchewan. Well, Saskatchewan is important because that's from where Tommy Douglas came. And let me read in the heels of the 50 years anniversary of Medicare what a visionary leader said. When we began to plan Medicare, we pointed out that it would be in two phases. The first phase would be to remove the financial barrier between those giving service and those receiving it. The second phase, he said, would be to reorganize and revamp the whole delivery system. And of course, that's the big item. That's the thing we have not done yet. Well, this is the beginning of the conversation of primary care. And before I even go any further, I want to recognize a special person. And that person is ADM Susan Fitzpatrick. And I will tell you why. Some time ago, Susan called for a committee where I had the privilege to be one of the representatives amongst 4 other healthcare organizations. And within that committee, we started to explore the in-depth works of primary care. And we formed 5 working groups. One that I had the pleasure to co-chair with Adriana Titley, who is also here, and that was the Access Committee. And this is the conversation we are here speaking with you. How are we going to ensure access to primary care for Ontarians? So in that committee, alongside the Ontario Medical Association, Ontario College of Family Physicians, the community health centers, and us, we looked with Susan at various issues. And one of them was, well, how many professionals we have in the sector? How many of these are working full-time, part-time, casual? And much to my amusement, and that of my colleagues in medicine, we were speechless because we actually didn't have on hand the numbers. Not only we didn't have the total numbers on hand, we also didn't know how many of those were full-time, part-time, or casual. So of course, having a well-oiled machine, as is RNAO, I went to Kim Jarvie, our health economist, and I said, Kim, go to the College of Nurses and look at the numbers of nurses we have in the sector. And I need to tell you that much to my surprise, we discovered that no, we don't have 1,000 nurses, we don't have 2,000 nurses, we don't have even 3,000 nurses, but we have 4,300 nurses working in primary care. Of those, about 2,900 are registered nurses, and about 1,300 are registered practical nurses. Now, if I ask any of you, as I did ask the Premier, the Minister, the opposition leaders, or any of you in the media, when you go to a primary care site and you see your physician, who is often who you see, did you see the nurse? And sometimes they look with shame, sometimes they look with surprise, sometimes they simply don't know. Neither, sometimes do I. So then I ask, let me ask you what the nurse does in that office. And then I say, not to embarrass ourselves, don't even tell me. Because for the most, these expert resources are utilized to less than 50% of their capacity, of their knowledge, of their competencies, of their skills. And that's the piece that Tommy Douglas is speaking about and that we are here to bring to your attention. We formed then urgently a task force. We launched it in February, and we said we need to absolutely put all the organizations that work in primary care and that serve people in primary care to actually put our heads together and make recommendations and an action plan to how to best utilize the registered nurses and the registered practical nurses in primary care. Many of the task force members are here today. Our colleague, head of the family health teams, Heidi is here. Our colleague, community health centers, Adriana is here. Our ADM, that actually opened our eyes for some of this, is here. Chief Nurse Officer is here, Deborah. Our colleague from Community Care Access Centers, and then of course, many other colleagues, including people from our board, people in various leadership positions in nursing and in healthcare organizations, and people from the various three parties. And we have an overflow room because that's the type of interest that this task force has created. So what did we do? First, we wanted to take an open, honest, and transparent discussion about what is it that our colleagues are doing, what is it that they can do in primary care, what are the barriers, what are the solutions, what are the challenges, and finally, what are our recommendations. In doing so, we decided the first thing to do was to analyze thoroughly and based on evidence of what actually these nurses were entitled, allowed to do based on their role descriptions. And we thought out role descriptions, not anecdotes, but actually written role descriptions from all the various models we have in the province in primary care. So from community health centers, from family health teams, from nurse practitioner-led clinics, from solo doctors' practices. And we put them side by side and did a systematic comparison, and much to our distress, we actually realized that there is no consistency in even the role descriptions of our colleagues. Now, some may say, well, it's based on what individual models need or what individual populations need. That would be good if those nurses would be utilized to their full scope. But no, some, as you know, are serving in administrative positions, others are doing minimal physical assessments, and others are doing the entire full scope of practice that a registered nurse can do and that a registered practical nurse can do. Let me give you one example of where I saw it in action. The Lakehead Nurse Practitioner-led clinic, when I went to this clinic to visit in Thunder Bay, I was amazed that within 8 months, they already had enrolled over 3,000 patients with 4 nurse practitioners. By the way, a nurse practitioner makes around $89,000. We will not compare it to other professions out of respect of negotiations. But we then said, so is it possible that with those 4 nurse practitioners, this is what's happening? And the lead nurse practitioner said to us, well, you should actually speak with the registered nurse to know the story of how did it happen here. And the story went like this, which is nothing systematic again. The RN says to me, well, one day I was speaking with our secretary and she said, we have all these patients waiting and we cannot get them in because the nurse practitioners are fully booked. And I said, let me see the list. And she said, I can do this, I can do this, I can do this, I can do this, I can do this. And of course, that clinic today is providing same-day access. So this is to say that we built a role description for registered nurses and for registered practical nurses based on reality, based on what RNs and RPNs today can do to deliver the care for the people of Ontario. And if our government and employers and all of us in nursing and other professions will move with this and fast track, I can tell you in 6 months after we fast track this, people in Ontario will have same-day access and at a lower cost. So what are the recommendations? Well, first of all, we are asking that the Ontario government immediately appoint a committee co-sponsored by RNAO and the Ministry of Health and Long-Term Care to roll out task force recommendations. Second, that the government and the LINs issue immediate directives to employers to utilize RNs and RPNs to their full scope of practice. Next, employers, educators, associations, and nurses work together to ensure RNs are empowered to conduct a broad range of clinical assessments and interventions, health education, and chronic care disease prevention and management. Yes, we can prevent chronic care conditions, and yes, we can do that soon if we put RNs to work to full scope. And yes, we can prevent complications. And that not only will decrease suffering for people, it also will decrease cost to the system. Next, government and regulators, and that's phase 2 of the recommendations, which we foresee happening from 2013 to 2015. Government and regulators work on legislative changes required to authorize RN to prescribe and dispense medications. I ask you, if they can do it in the UK, why not in Ontario? Are we alone on that? No. Alberta, Manitoba, and BC are also moving to RN prescribing. Next, government and regulators work on legislative changes to authorize RNs to identify and communicate diagnosis. Next, government and regulators work on legislative changes to authorize RNs to order diagnostic and lab tests. It is unconscionable that a person coming to a family practice setting today with symptoms of a urinary tract infection cannot have the registered nurse look fully after that condition. It is unconscionable that a person coming with a child with an earache cannot fully take care of that condition. And the same goes for a sore throat and many other conditions. And then we will free up. We will free up NPs, nurse practitioners, to do higher level of complexity, and yes, we will free up family physicians to do only the complex necessities of patients. Then we are asking for LINs and primary care nurses and primary care organizations to utilize registered nurses to coordinate care and patient system navigation. And last, employers, educators, associations, and nurses work together to ensure that RPNs, registered practical nurses, are empowered to take leadership roles in evidence-based clinical and educational health programs. Examples, again, from reality, not only in Lakehead Nurse Practitioner-led clinic, but also in many of our community health centers. RPNs can and have the expertise to run, for example, a wound care clinic. Yes, they can provide the vaccination programs. So, we are saying to government, let's move immediately, and we are saying to the public, demand that because you could have same-day access to care at a lower cost for your taxes if we move with these recommendations. Thank you.